So I would first like to thank Dr. Brayman, not just for what he is teaching us today, but for his contribution to medicine as a whole. If we are here as a group of people who believe that preventing disease is more powerful than just treating disease, then I would submit that Dr. Brayman is both a pioneer and a leader in some of the most important work that could possibly be done in the world. Is there anybody in here that would agree with that statement? Show of hands, show of hands. So there you have it, Dr. Brayman. You have been elected by your peers as a pioneer and a leader in some of the most important work that could be done. And I appreciate all of your mentorship and help. You're a great person. So I have a couple more questions for you. How many people know what direct primary care is? Okay. How many people know somebody personally who's doing direct primary care right now? Okay. And how many people in this room are doing direct primary care? 1, 2, 3. 3 in the room. All right. Welcome. One last question. How many people in the room are over the age of 34? Okay, that's my last question. So the reason I ask that is because I am not going to try and instruct my superiors today, but I do think that my story could be instructive in helping to understand the forces that will be important in getting the manpower into Dr. Brayman's system that he's talking about. And I think that because I think my story is probably a common one in some ways. And it starts with the wrong PowerPoint presentation. And it starts in the year 1987. And in 1987, I'm 5 years old. I'm in Albertsons holding my father's hand. And don't do the math here, yes, I am young. So at 5 years old, I'm holding my father's hand, and a lady comes up to us and says, as she looks down at me, she says, "Do you know that your dad saved my son's life?" And from that moment on, I realized that my father was a hero. And I wanted to be like him. I wanted to be involved in whatever kind of work would produce this kind of interaction where a woman would come up and say with tears in her eyes that your father saved my son's life. So fast forward to a few years later, I'm a senior in high school working at an alternative medicine clinic, and I'm learning from some of these people that maybe saving lives also includes preventing disease with nutrition and lifestyle. And there was some other things that happened in that clinic that I maybe didn't agree with, but that concept stuck with me, and I took it to medical school, where in 2009 I started medical school. And I started seeing on the slide sets that my teacher were putting up that the risk factors of these diseases include smoking, obesity, alcohol use. I saw those risk factors on the slide. but I never heard anybody talk about preventing the disease. And I wondered, so when do we start talking about preventing these diseases? And so it was only on my own research that I started to find things like this. We've thrown around some statistics today about how much of disease might be preventable. Well, this estimation says 66% of disease may be preventable just through lifestyle measures alone, as well as this one that puts that number higher, like 78%. And so as a third-year medical student, I'm on an inpatient rotation, and I have this list of people that I'm going to see at 5 o'clock in the morning. One of them's got a new stroke, one of them just had a heart attack, one of them is septic from a diabetic ulcer, one of them's got cirrhosis, and I'm looking at this list and I'm comparing it to this last statistic. Could 8 of the 10 of these people here now be home with their families, enjoying life, if we were doing a better job at preventing disease? And I asked myself, why are we not preventing these diseases? And I know it's more complicated than this, but the best answer I could come up with is we're not really trying. 5.1% of our healthcare expenditure went to primary prevention and screening in 2004. And the numbers aren't too much better today from what I understand. So if this is how much we're spending to try and prevent disease, then what's the rest of the money being spent on? Well, 75% of it is being spent on treating the consequences of preventable disease. So here I am as a medical student with all these people that I wish were healthy and wondering, why aren't we treating them? And so next year I'm graduating from medical school, I'm starting residency, and at this point I am a much younger, much better looking, and more arrogant version of myself. And I'm thinking, hey, I'm the quarterback here. I'm a family physician, and I'm going to be directing where those healthcare dollars are spent. So what I'm going to do is I'm going to do prevention. I'm going to learn all the USPSTF guidelines. I'm going to talk to every patient about lifestyle, about nutrition, about exercise. And so I start doing it. And I'm doing it as hard as I can. And I start to find that, first of all, it's a little bit difficult in a 15-minute visit. This was a study, this is probably a really generous number actually. This is a study done off videotaped encounters. So how many people are going to maybe spend a little more time with a patient if there's a video in the room? Just saying, I don't know. And I'm also learning that if I was just going to do USPSTF recommendations, it'd take me all day long, every day. That's all I would do all day, every day, is USPSTF recommendations. And if I happen to maybe want to address some of the concerns that people come to my office for, then it's going to take me all day and all night, every day of my life. So I wasn't quite ready to do this, but I tried. I was getting there at 6:30 every morning. I was making a plan for each patient. I had a typed plan for each patient of the day, and then I was spending way too much time with each patient. I was working straight through lunch, and I ended up seeing patients till 6:30 in the evening. The MAs literally would draw straws to see who had to stay with Dr. Johnson this time. Of the 20 other people in the clinic, every time I'm the one staying till 6:30 at night. And then I go home, have a quick dinner with my beautiful wife and 3 kids who are wondering who the stranger in the house is. And then I go and I make some more phone calls to patients, honestly, like on a nightly basis. And then I go and I do notes till 11 o'clock at night. And this is me as a first-year resident and thinking, okay, I can just get more efficient. Second year comes around, and I'm actually finding more things that are important to do. I'm not getting more, I was getting more efficient, I was doing more, but I was finding way more stuff that I could and felt like I should be doing for my patients. So how did I feel at this point? And this is what I wanted to talk about in reference to Dr. Brayman's view of the future, is how do we get people like myself to be able to envision a future where this system works? And my view at that point was, I've got 2 options. I've got the option to continue what I'm doing until I burst into flames, or I've got to just compromise. And I've got to just find myself within the system that's there. And I've got to do, you know, what I can do in my 15-minute visit, if I even get 15 minutes. And both of those ideas, both of those possibilities seemed like death to me. I had worked so hard to be there. And it looks like there was not a place that I wanted to be. It looks like the place I wanted to be didn't even exist. And I was desperate. This is only 2 years ago. And I thought that my career was just over or something. I didn't know what was going to happen. So I'm looking around at this point to try and figure out, are there other options? What else can be done? And I think, well, I don't need that much money. So here's what I'm going to do. In 2015, I'm getting ready to make career plans. My colleagues are starting to accept job offers, and I think, I'm just going to see less patients. I'm just going to have my own practice. I'll make this little practice where I see less patients, and I'll just make less money. And I start to do some of the math on that. And here's some of the math that's important for that model. That most primary care offices have between 50 and 70% overhead. So say I want to see 30% less patients. Well, I might have like $5 to take home at the end of the day. If I take out 30% of my practice, 30% of my revenue, that's all of my net revenue. And of course there are more efficient systems. Of course there are other things that come into play here. But this still looks pretty bleak to me. And as I look around, I find a group of people doing what they call direct primary care. And I'd heard about the name direct primary care in the past, but it sounded like concierge medicine to me. And I'm like, I'm not going to spend the rest of my life catering to rich people. You guys, some of you are rich out there, and I like you. I don't have a problem with you, but I don't want to just spend my whole life just doing whatever the rich guy tells me to do. So concierge medicine did not sound like a good idea to me. But as I learned more about direct primary care, I realized that that's not what it was about. Direct primary care is based on a question. If insurance-based practice is based on one question, it might be, how many RVUs do I need to bill in a day in order to keep my practice open? If direct primary care is based on one question, it's how many patients can I take care of in the way that I feel like patients should be taken care of? And to figure out that number, there's a few different ways you could try and come up with an answer, but one of those ways is to look back at this slide where it would take 21.7 hours just to do these minimum things for a patient. So if we use that math and we give ourselves an hour a day for administrative time, then that means that I can see maybe 800 patients. I can have a panel of about 800 patients. Well, what if I would also like to talk about lifestyle? Those numbers were not factored into that previous study. So what if I also want to talk about lifestyle? I don't know how long that's going to take. It seems to take me a lot of time, but Dr. Brame is going to help me to learn how to make that more efficient. What if I also want to take my own call? What if I want to listen to my patients a little bit? Spend some time with a depressed patient and just hear their story. Well, so here's the rest of my math. Bippity boppy boo, 600 patients. That's about how many patients I think I can maybe take care of. And I don't know the actual answer yet, because right now I'm at about a third of this in my practice. But this is kind of what we're shooting for. So in order to figure out with 600 patients, how do I make a living taking care of 600 patients? And I think either you got to find the world's most magical billing encoder, or you got to find a different system. You got to have a different system in order to do it. So an important part of the math in direct primary care is overhead. You know, we looked at this 70% overhead in insurance-based practice. The average direct primary care practice runs closer to 25%. It looks like I'm going to be able to run my clinic around 20%. And so that's an important part of this math, because as we go to our next slide, and I want to make about $200,000, you know, sure, more would be fun, but $200,000 is probably all we need. And so that means that we need about $266,000 of gross in order to do that. So 266,000 divided by 600 patients, 12 months. I need $36.90 per patient per month in order to have, you know, a reasonable living. Well, we won't debate about what a reasonable living is, but to pay out my $400,000 in student loans, this seems like a good number. So this is the math behind direct primary care. There's lots and lots of nuts and bolts about direct primary care, and we'll see what we can get to try and talk about those. But let's finish off the story. 2016, I graduate from residency, and I do about as much hospitalist work as I can stand, so I can earn some money to start a practice. A partner and I both put $20,000 into a bank account, and in October of last year, we move into an office. November, we officially start, and 2 months later, 2.5 months later, in January, we start breaking even, which was greater than our expectations, and a huge blessing, because now the worry about, you know, is this going to bankrupt us is now gone. You know, we might spend a lot of time not making very much money, but at least we know it's not going to bankrupt us. And then right now, we have projections that by next year, then our practice will be full, and we will, you know, have the kind of income that we want. So that is the basic story of how I got into direct primary care. But I have one more story for you, and it is the story of just one patient. But I can tell you, if you want to come up to me afterwards, I can tell you at least 20 more stories that are comparable to this one. There's a patient named Jane, fake name Jane, who came into the practice, and she had not had a primary physician for years and years, over 10 years, she said. She'd been to urgent care to get refills on her prescriptions every 3 months or so, whenever she runs out, or as long as they will give her enough of a prescription. And she just avoids the doctor as much as possible. She's not well physically or emotionally, and she comes to me and she's on 4 medications. And her membership in my clinic is $75 per month. That's how much it costs for her to come in and see me anytime she wants to, anytime she needs to anyway. And so I sit down and spend an hour and 15 minutes with her that day, and we talk about her major health problems, and more importantly, we really try and address her psychosocial factors in her health, and get her on a plan that since last time I saw her is changing her life, she says. And that day, I was able to send her home with a 3-month supply of all 4 of her medications that I pulled out of my closet in my office, and that 3-month supply cost her $30. So those medications were previously costing her over $150 a month. So if we do that math, then every month that she's a member of our clinic, she saves $60 off of just what she was spending before on her health care. So that's including her membership plus the medicines. She saves more money than she is spending in our clinic. And Jane was crying as we told her what we were going to be able to do for her, and she said, "I've never had a doctor treat me like this, and I can't believe that I'm now going to be able to get, good health care and also save money." So I have quite a few stories like that, and I'd be happy to share any of them with you. But to me, her story represents a dream come true, literally. And if I could see that interaction 2 years ago, when I thought my career as a doctor was as good as over, that would have brought me a lot of hope. And that's a kind of hope that I would like to be able to share with others, especially those who are just trying to figure out what kind of medicine they're going to do. Are they going to avoid primary care altogether because of the math involved? And once they are in primary care, are they going to just find themselves a slave to a system? Or are they going to get to do what they dream of doing? So that is my contribution to some of the possibilities that might fit into this system that we should design and need to design, and maybe direct primary care could be a part of that. And I'll take any questions.